Good morning. Good morning, everyone, and welcome to our first panel discussion of the day. It's a discussion around maximizing the waiver model here in the state of Maryland. My name is Maria Harris Tildon, and I am the EVP for Public Policy and Government Affairs at CareFirst, BlueCross, BlueShield. I am honored and delighted to be here with some extraordinary experts on the waiver here in the state of Maryland and healthcare policy experts. In fact, as we were talking about our long history in this space. We've got Bob Atlas, who is the president and CEO of the Maryland Hospital Association, and Joe DeMattos, who is the president and CEO of the Health Facilities Association of Maryland. Very shortly, we will be joined by Josh Sharfstein, who is the vice dean of public health, practice, and community engagement at Johns Hopkins Bloomberg School of Health. I think Josh is in the throes of joining us any moment. We should give him 1 or 2 more seconds to visit with us. We hope that this will be a very robust conversation, very casual and informal, as you have folks that have lived the Maryland waiver model for many years and have very specific perspectives on its successes and the opportunities for improvement as we move forward. I encourage those of you who have joined us this morning, there is a chat box that where you have an opportunity to suggest questions, and we will do our best to answer them as we move along.
Well, Maria, if you want, we can maybe switch the order. I don't mind. Whoops, where'd Maria go?
Hopefully Maria's still there.
Oh, there's Josh.
There's Josh. We got Josh and we lost Maria. Maria, I hope you'll continue to join us. Hey, Dr. Josh, how are you? Can you hear us? Bob Atlas is going to present in a moment, but we cannot hear you yet, Josh. Can you hear us? Great. You can hear us while you work on the sound issues and get that resolved behind the scenes. Bob, do you want to start with your presentation?
I will go ahead if unless Josh is. No, still can't hear you.
All right, I'm going to call our colleagues at the State of Reform. Bob, start with your slides, and I'll call.
We don't want to waste people's time here. So, all right, I've got a few slides to show, so let me do that. Put those up for everybody. Josh, are you audible? Try now.
How about this?
Good.
Okay.
You can hear me now?
Yes, we can.
Very good.
You were going to be our opener. I'm going to pull my slides back off and somehow, and you can have the floor. Go ahead, Josh.
Are we public?
We are live. The world has seen us. We have about 20 people in our room right now.
Oh, okay, fantastic. And we're waiting for Maria to come back?
No, don't worry about Maria.
Don't worry about Maria. Okay, Maria's coming back.
We love Maria. We're worried about Maria.
Okay.
But
we're having one of those moments.
Wait, hold on.
There she is.
Maria already did the intro, so you're up.
Oh, okay. All right, fantastic. So I'm Josh Sharfstein. I'm a faculty member at the Johns Hopkins Bloomberg School of Public Health, and I was the secretary of Maryland's Department of Health and Mental Hygiene when the Maryland model was developed and adopted. And I believe my initial role here in this session is just to remind everyone why we did this and what the major goals were. And then we'll get a real great update from Bob about how it's going, and context from Joe, and then the conversation with Maria. Pay no attention to the fact that my camera just went off because it's right back. Okay, so I'll take you back, eons ago, back to 2011, 2012, when there was a kind of a crisis in the healthcare system of Maryland. We had this system of rate setting for hospitals that had been in place for 30 years. and had done a lot of great things for the state, but it was on a shaky foundation. And the shaky foundation was caused by some general healthcare trends and some challenges in Maryland. And that led to a review with the Centers for Medicare and Medicaid Services and the federal government of how things were going and whether the system that had been developed could be built upon. And that led to, there's Maria. That led to an opportunity for the state of Maryland. The federal government was prepared to continue to invest and support the state of Maryland if we could accomplish what the federal government at the time was calling the triple aim, better health, lower cost, better patient experience. And the federal government essentially challenged Maryland. We know you've had this system for 30 years, they said, but how can you improve it, and how can you help improve health in Maryland, control costs, and improve patient experiences through the whole care continuum? And at that time, a lot of different groups in Maryland came together, including the hospitals, the long-term care industry, physicians, consumer groups, others in the healthcare system, to consider alternative approaches. And the idea that was developed was called global budgets. And the idea is that instead of relying on the historic fee-for-service reimbursement approach, where you have to have a sick patient to be paid in hospital care, that Maryland could shift, building on the system that it developed, to a budget for the hospital that would be set in advance and would give flexibility to the state to and to the hospital to invest in different models of care and prevention and be able to keep the difference if in fact they were successful. The way I used to describe this in part was, in every other state, if somebody developed a great program that kept older adults from falling and breaking their hip, then that would save Medicare all this money because they wouldn't have to care for these hip fractures. But every dollar of savings would go to the federal government because the federal government wouldn't be paying for it in Medicare. Whereas in Maryland, if we developed a system like that, then we could prevent people from falling, and that would be good for them. But it would also the savings would be shared with the federal government. Some of the savings would stay in Maryland, so we could actually invest in those kinds of programs. And in fact, we've seen Maryland hospitals invest in exactly those kinds of programs across all of these different areas. And so the goal here was not just to improve, the financing of hospitals, which I think it has done, but also to create this incentive to care for patients better in Maryland, to have better outcomes, to have fewer older adults with hip fractures, fewer kids with asthma, as we are creating better models of care at each level of care. So that was the idea. And I think, like every major new innovation, it's had some successes and some challenges, which we'll talk about today. But overall, I just say that when we put it forward, there was an astonishing amount of support for it, given how contentious healthcare could be. And I think that really reflected well on the Maryland healthcare environment, that people could come together, roll up their sleeves, and develop an idea like this. And that spirit of cooperation, leadership from industry, as well as consumer groups, has really persisted and made it possible for this initiative not only to have been proposed by a Democratic governor and approved by a Democratic president, but re-proposed by a Republican governor and reapproved by a Republican president, with just a tremendous amount of support, because it allows Maryland to do things in a very creative and innovative way, focused on improving health and controlling costs. So maybe I'll stop there, Maria, and turn it back over to you.
Yeah, and Bob, I'm going to turn the conversation over to you to provide a little bit of context and table setting for performance today.
All right, thank you, Josh, for the setup. Thank you, Maria. So I've got a few slides here. Let me just move right on. So Josh gave you a kind of a word picture of what has happened here. I'll quickly kind of put a picture to the picture. So we had simple hospital price regulation, if you want to call it simple, for 40 years, really, from 1974 to 2013. Importantly, a feature of that was not just hospital price regulation, but the fact that all payers pay the same rates. So if you receive a particular procedure at a particular hospital, whether you're Medicare or Medicaid or under an employer-sponsored insurance plan, the payer pays the same rate. And that is another important feature of our program. It saves our payers from cost shifting. As I'll show in a second, it gives a real benefit to the employer-sponsored insurance sector. Beginning with the model that Josh described in 2014, with the hospital global budgets, they were added. So each time we advance the model, something happens where the previous features are largely kept, but new features are added. So we added the global budgeted revenue in 2014, and importantly, in there also added incentives for utilization and quality. Some people will say, well, if you have fixed revenue, you could threaten quality. We have significant incentives, significant measuring of quality, significant incentives on quality, and that is really important for people to understand. Any hospital in the state has as much as 7% of its inpatient revenue at risk for meeting the quality objectives that are set. And then after success in that 5-year period, we launched the newer version of the model, which is now called the total cost of care model. It still has all those same features that were built in the first model. And now we have this important total cost of care element, which has hospitals being partially at risk for not just the hospital care that Medicare beneficiaries use, but also for what they use outside of the hospital, whether that's physician services or post-acute care services and so forth. The one thing that is excluded, of course, is prescription drugs, outpatient prescription drugs. That's under Medicare Part D. And more recently, some extra features have been added. We have an approved statewide integrated health improvement strategy that puts the whole model, adds a tremendous focus on community health and population health. And then importantly, and we at MHA have really doubled down on this since we started more than 5 years ago on our health equity pursuits, really aimed at eliminating health disparities, which do exist in Maryland. Racial disparities are quite pronounced. That's true all over the country, but we are no exception to that. Just a little bit about how we've done. So this is the savings. It's against a baseline from 2013. So under the all-payer model, we generated well over $100 million savings a year. Under the new model, we had a target in the first year of 2019 of $120 million. We well surpassed that and saved Medicare $341 million. You see the dotted lines, those are the official targets for the next 4 years. And we expect, that 300+ million will sustain all the way. So we're already meeting the target for 2023 in terms of savings. We, as I said, employer-sponsored plans get a good deal here because, and as you see this depicted here, so Maryland has the second lowest in the country per capita costs for hospital services, both inpatient and outpatient. Can't tell you why Hawaii is lower. I guess just being Hawaii. we've on quality metrics. Here are three Medicare readmissions. So in every one, the green line is Maryland. We started higher than the nation on Medicare readmissions. We're now we went down fast, and we're well below the national average. 30-day mortality, we got below the national average pretty quickly, and we've held that. And we've reduced potentially preventable complications by more than half during the time that the model has been operational. So I do want to talk a little bit about the future, but I think I'm going to take the slides down for a second, let my colleagues have the floor for a bit. And whoops, hang on a second. All right. Did the wrong thing push the wrong button. There, gone. Okay. Over to Maria and Joe to share their thoughts.
Yeah, as Josh framed up beautifully, the fact that we have a waiver in the first place is an extraordinary accomplishment. Many people at the table, many stakeholders, to Josh's point, had to roll up their sleeves and reach a model that worked for the entire ecosystem. Lots of incredible successes along the way. Bob mentioned, or Josh mentioned, significant declines in emergency room visits, a shift from for those services to lower cost settings, and an overall reduction in healthcare spending. It also created an environment where a mindset where there's more of a focus on the broader population health. And identifying ways and innovative initiatives that can be brought to bear to drive down overall costs and improve the quality, particularly for Medicare members. One of the things that I think is most illustrative about the success of the waiver is the way that hospitals have fared, particularly during the pandemic. As we all know, across the country, the pandemic caused significant financial strains for hospital systems. Our hospitals, because of the GBR, had the flexibility and, frankly, the cushion to be able to weather those financial challenges when utilization went down, and then the potential for increased costs related to the treatment of COVID patients. One of the things that we are really excited about, and I'm so glad that we have at least a part of a slice of the stakeholder community on the call, is in spite of all the successes that we've realized over the past few years, we are just on the precipice of renegotiating the waiver. Rolling up our sleeves once again with stakeholders around the table and with CMS to identify ways to reimagine how we can do better, how we can not only improve health outcomes and costs related to our Medicare population, but how do we extend some of those best practices, some of those initiatives to drive outcomes in the broader population. It's particularly critical as we've seen. COVID has laid bare dramatic healthcare disparities, and so how do we create a process? How do we create an approach and a model that ensures that not just the Medicare population, but those populations, those in the Black and Brown communities across the state, are actually also benefiting from the interventions that are brought to bear? And then how do we ensure that we set up a process that allows for us to measure the outcomes of those initiatives that we invest in, to ensure that that the dollars that we are investing in the work and in the initiatives is actually reaping benefits. I think SciHIS that Bob mentioned earlier, which is a new approach in the early stages of implementation, focusing on maternal and child health, focusing on opioids and behavioral health, really sets us up to begin the process of expanding the aperture of the kinds of initiatives that the state focuses on beyond the Medicare population, that ensures that we address some really damning numbers in terms of health outcomes in the state of Maryland. I'll kick it to Joe.
Thank you for that, Maria. I really appreciate it. And I want to, it's such an honor to be here with my colleagues. I always start conversations like this with saying something very explicit. And that is, we have to thank Josh for his leadership as health secretary. We had this long history of having a statutory waiver that we're talking today about in relative to the total cost of care contract that we have with the federal government. And that waiver, now the total cost of care contract, awards financial flexibility, care integration flexibility that benefits our economy, but more importantly, real Marylanders in need. And at the time of this renegotiation and moving from statutory protection to a contract and then to a total cost of care, there was a really good chance that we wouldn't be able to secure the initial contract. And Josh took a lot of hits, a lot of political hits at the time. And we've got to remember that we owe him a bunch for this. So let me just start with that. Let me also say something very basic, that public policy has consequences. Public policy has consequences. And in healthcare, those consequences are measured in the life and death experiences of Marylanders in need. When you think about healthcare, you don't really, we all work it every day, and we think about payer source and point of care and where the care is being delivered and integration of care. But in the end, somebody in need, whether they're covered by BlueCross, BlueShield, who I really admire, and CareFirst, or Medicare or Medicaid, whether they're receiving a care in a doctor's office, a hospital, or a skilled nursing and rehab center, they're just dealing with the medical challenge that they're dealing with. And I will say that as we've moved from a statutory waiver to an initial contract relative to hospitals, as Bob outlined so well, to a total cost of care contract relative to the entire landscape of healthcare, that we are doing better, not only with regard to the savings and the outcomes that Bob spoke of, but relative to the integration of care. Let me add one current perspective from a skilled nursing and rehab point of view, and then sort of maybe cast us into a future conversation of maybe where we go with the total cost of care contract. Maryland, again, public policies have consequences. So as a result of, unrelated to the contract, Maryland skilled nursing and rehab centers were ahead of the national trend in providing quality care to highly sort of chronically acute patients and residents ahead of the rest of the country. So the people that receive care in Maryland skilled nursing and rehab centers have multiple comorbidities. They're sick on a number of different levels. They most often have some form of dementia, congestive heart failure, maybe diabetes, maybe renal failure, bunch of stuff. And because of policies unrelated to the total cost of care contract, Maryland sort of was the spear in the country, led the country in beginning to take care of folks like that, Marylanders in need, in skilled nursing and rehab centers. Now, while the rest of the country was declining in terms of Medicare referrals to skilled nursing and rehab centers, because of the total cost of care contract, we were actually maintaining our ground with regard to Medicare referrals to skilled nursing and rehab centers because of the total cost of care contract. The contract doesn't work if hospitals don't have a partner in skilled nursing and rehab centers to have people go from the hospital to the skilled nursing and rehab center to get stronger before they go home. Now, obviously, COVID put a big left or right turn in that because people weren't going to hospitals for that care, right, in the COVID environment. But that's that. Now, let's talk about the way forward. The way forward, the total cost of care provides an incredible potential framework to do a couple of things. To get at the healthcare disparity issues that Maria spoke of, and population health issues that Maria spoke of, in an environment of partnership and collaboration across the care continuum. Social disparities of health, workforce issues, and public determinants of health pre-existed before the COVID pandemic. And the pandemic shined a bright light on them. And they said, look, we got to work better on this. I personally think that the contract creates a framework where we can work on partnership on those issues, press down on the length of stay on skilled nursing and rehab centers relative to all payer sources, but also realize that there'll be new opportunities for all of us to move from vendorship, that is, that the skilled nursing and rehab center is the vendor of the hospital, to a system of partnership where we work in partnership to achieve greater healthcare outcomes, attack social determinants of health, and reduce the total spend. In the end, public policies have consequences, and to all of these issues, there is a face of a Marylander in need. So, Maria, I'll send it back to you.
So, I'd like to offer others to have to respond, but I do want to note the opportunity that we have, Joe. Obviously, with respect to your population, the waiver is specifically focused on creating incentives for those kinds of partnerships with the hospital system. So, as we sit in the throes of having to come up with a new way of thinking, we have an opportunity to do some curb jumping. How do we very thoughtfully and carefully create a model that generates the same kinds of incentives that drive those kinds of positive outcomes from a quality clinical outcomes and cost in the broader population?
Maria, I'm going to jump in as we transfer and get Josh's Bob's thoughts on that. You nailed it. You asked precisely the right question, which I'm not surprised about. I think, when somebody, when a family member or any of us individually are facing a clinical medical challenge, right? What we want to know is we're going to be all right, and we want predictability on how we get all right, right? And so it's the same in healthcare, and we want control. And often in healthcare, Josh will tell us, often so much is out of our control as patients and families, So we want control, we want predictability, and we want to know it's going to be all right. And so in curb jumping and the way forward with the contract, skilled nursing and rehab centers as a critical partner want the same thing. We want predictability, we want to know what the rules are, and we want to be able to deliver a quality product and be allowed to make the decisions that allow us to do that in partnership. So Josh, I'll throw it over to you.
Go ahead, Josh. You're muted.
I've got a mug that says you're muted. I'll send it to you.
There we go.
Hey.
Actually, I think I'm going to defer to Bob on this from the provider perspective, because we've got two great questions in the chat that we can go to next after this.
Yeah, well, I'm going to take a second, just put up my one remaining slide, and that is, we are very focused on the future. We're performing in the present. Notwithstanding COVID or even because of COVID, our hospitals have acquitted themselves remarkably well over the last 14 months. Our payment system has helped with to sustain the viability of hospitals. And I think it's important to say, just a couple of hours ago, I was talking to our current health secretary, Dennis Schrader, and he noted that one of the things about our model that people kind of take for granted is, in Maryland, we don't have a two-class system of hospital care. We don't have public hospitals. We don't have hospitals avoiding taking care of patients because they don't pay well enough. And we also have a very robust system of care for rural communities. Hospitals in rural communities around the country are really threatened, and they're closing in large numbers. And in Maryland, our system with global budgets really sustains the hospitals and improves access, assures access throughout. But thinking about the future, our hospitals are most importantly thinking and acting outside the box, figuratively and literally. Our hospitals are reaching out into their communities in ever so many ways. You've heard this term, social determinants of health. Our hospitals are dealing with the social needs of individual patients. If somebody needs help with something with social needs after leaving the hospital, we're there for them. If a community needs help with issues of housing insecurity or food insecurity, our hospitals are also working on that. Really to a very great degree, and we're in the process of documenting and demonstrating that. One of the things that we need going forward is we really need to build that population health strength. We really need the full commitment of our state government, and all indications are that they are there. We're excited to have that partnership. It's a matter of not only the health department itself acting with all the levers it has on public health, but all aspects of state government, whether it's the Department of Aging or Environment or Labor, we all have a role to play in the way that laws are passed, policies are delivered, and budgets are allocated. And then, as others have suggested here, we need broad shared engagement and accountability from our non-hospital care partners like the primary care physicians, and we have this robust Maryland primary care program that's kind of a companion to our model, all the way to post-acute care, which Joe represents, and the payers. The payers have a big role to play because of the way that they administer health benefits and can potentially invest in communities. I'm going to stop there, pull the slides back down, and let others chime in. And I know we have some questions in the chat now.
So one question from a fellow that I know very well is, given the current pace of innovation in healthcare, how do we ensure Maryland stays at the forefront as we work through the next phase of the waiver? I'm going to take a whack at giving a short response, and then I'd like to offer the opportunity to my fellow panelists. And this is, I can't underscore the urgency that is before us, and the opportunity that negotiating this next phase of the waiver really does present. I think there is an expectation that we are to deliver something that looks like more of an all-payer system that addresses more broadly a population health approach, which is again going to require a very, very broad range of stakeholders, not the least of which, Bob, you just named the state government, and just about every agency needs to be at the table. This is not not work that can and should be borne by hospitals alone. But again, we need to come up with strategic ways to get at care coordination and cost savings. That means stepping into value-based arrangements and getting acclimated and comfortable as a state and as stakeholders in adopting arrangements that frankly have been incredibly successful, not only in federal programs, but in states across the country where providers, carriers, and other stakeholders are looking at the entire panel of patients, their outcomes, and we're moving away from a fee-for-service system. So how do we get to a place where again the lens is not shining specifically and only on the Medicare population, but ensures that those innovative processes, those innovative interventions that the Medicare population has enjoyed because of the, frankly, the incentive that hospitals have under GBR and the waiver. How do we extend that to ensure that more of our citizens benefit from that close strategic approach to coordinated care?
I guess I'll jump in here, Maria. Great point about value-based purchasing or value-based integrated healthcare. I think we will absolutely see more value-based healthcare in Maryland and across the country going forward, and to integrate some of the questions in the queue with some of the comments that Bob and Josh made. So first, Bob, I think the contract, again, just to be explicit, one of the huge value points of the contract in Maryland is we don't have a two-tier charity system. People in Maryland can show up at a hospital, the best hospitals in the world, and receive quality care and have a great shot at fighting for their lives and their quality of life going forward. That can't be understated. And relative to what Josh said earlier, the challenge in some of these federal demonstration models in the past is that cost savings went back to the federal government, or in some case, cost savings went back to the hospital in sort of an upstream, downstream model, as opposed to a one-stream model where everyone takes risk. Everyone is then able to know what their decision points are relative to that risk. So physician, hospital, skilled nursing rehab center, know in advance, here's the incentive, here's the risk, here where you're empowered to make decisions relative to that risk, and then here is the reward for achieving a better healthcare outcome with that person, right? And so the contract allows us the potential in Maryland to sort of avoid the problems that have happened with other demonstrations, with the money either going to the federal government in terms of savings or upstream with a perception to a hospital as opposed one stream. I want to end with these three concepts and then throw it over to Josh for some thoughts. Think about where we go with the contract is kind of where we've been informally in the COVID-19 pandemic. The fact that we are all having this conversation, and often we have this conversation with Gene Ransom from the docs, and the facts that over the last year and a half, we've been on the phones and on the internet and on Zooms with one another constantly. We are more integrated than we ever have been. Telemedicine is more in use than it's ever been. So going forward, the contract affords us an opportunity of all people, all provider, and this area of shared responsibility that we're speaking about.
Yeah, and if I may, I really appreciate, Joe, your recognition that you got to have skin in the game, right? And part of the success of some of the national models, some of the federal models, is the fact that there is that downside risk, right? And there is a motivation to develop thoughtfully those kinds of interventions that will really drive the kinds of outcomes that are necessary, and not just, again, for the Medicare population, but for the broader population. With all that, with the appropriate data and information for all partners and all stakeholders around the table to make really informed, thoughtful, not only decisions, but strategies and the different kinds of interventions that they bring to different populations.
I see Josh is jumping in.
I was just going to say, I do think that a lot of the innovations have helped more than just the Medicare population, and that there is now a focus in the state level on maternal child health, particularly for a big project. But I wanted to call attention to two questions that have come in and how they are, in a weird way, two sides of the same coin in my mind. One of the questions is, how does Maryland stay at the cutting edge of healthcare innovation? In other words, there's a new surgical technique, there's a new technology. How do we make sure that that's available to people in Maryland? And the second is, how do we get more community and state collaborators to join together with hospitals to address social determinants of health? And those might seem like two very different questions from two completely different perspectives. In my mind, the way I think about it is that we have a very unique way of paying for healthcare, that things that are necessary in other places, the volume of services that may just be part of the standard of medicine to do in an inpatient setting, for example, we don't have to do it that way. We can rethink how healthcare is provided fundamentally. And that creates room for both different kinds of innovations as well as traditional innovations. We have an incentive in Maryland to find interesting technologies that keep people out of the hospital, keep them healthier, and to invest in them even. And so the more that we can do to shift out, the preventable illness, to reduce the preventable illness, to shift out the things maybe that are not medically necessary, that may be done in other places that are standard revenue generators. We don't need that in our system. That creates room for other things, and it creates room for going further upstream and thinking about what is driving poor health. Maryland hospitals and Maryland's healthcare system has a very unique alignment of incentives with better health, and that creates an alignment both with social determinants of health investments and also with the other question that came in on racial equity. So realizing that alignment, is the challenge. And you see the signs of it. You really can see the signs of it. There are hospitals invested in a housing intervention with the state under a novel Medicare waiver to get more supportive housing. Hospitals are in different ways much more open than prior, I think, to the model in doing co-investing in different projects with community organizations, but we're just scratching the tip of what's possible. And if we can continue to see the value of changing, transforming the hospital system, particularly, that creates openings at the technological end as well as at the more socially engaged end for innovation. It'll create more funds for that. We have a lot of flexibility in Maryland to do that. And, there are a lot of reasons to do that. It's both the reasons that we want to have, the latest and greatest effective technologies, but it's also the reasons we want to address some of the really unjust, longstanding issues that have existed in Maryland as in elsewhere. And, I think that I do appreciate that in many ways Maryland has reduced the disparities and inequities in healthcare, but it is not at all eliminated them. There are many that are there, and there are many people who don't have insurance and people who can show up and get huge bills, and all of those things inhibit health one way or another. And so when you have a fundamental alignment with health, it's about, using that incentive structure to get out the things that really aren't necessary, and bring in the things that we really want to do. And that creates this alignment. We can have a healthcare system that is both the most cutting edge and the most interested in dealing with some of the fundamental drivers of health at the same time. And what makes that possible is the shift that's happening in healthcare.
And Josh, what I heard you say is it described, to put it more simply, as innovation will unlock, frankly, funds and dollars that can be reallocated to ensuring that we move some of those services to lower cost settings. But also, you have an opportunity to take those dollars and invest in areas where we know upstream on social determinants of health going to have a long-term impact on clinical outcomes and quality of life that do get at those disparities that we all saw brought to life as a consequence of the pandemic. So it really is making smart strategic decisions about where we make our investments and ensuring that providers, hospitals have the dollars that they need to make those investments in improving more effective treatment, but also the opportunity to push the treatment out to lower cost settings.
So speaking of those hospitals, so I'll just say, and one of the questions in the chat mentions lessons of the pandemic. So there's a technology. At this point, it's not much of an innovation. What's the innovation is the use of it, and that is telehealth. Became really a lifesaver on a large scale during the pandemic, when people couldn't leave home or couldn't access care physically. And, the use of telehealth was a real boon for people, particularly those who are homebound. And we really we've succeeded in getting legislation passed to embed some of the new flexibilities for telehealth. And, you might say, well, why would hospitals want people to get care over the computer or the phone rather than come to the hospital? Well, by now everybody should understand, our hospitals don't make more money when people who don't really need to be in the hospital can get care in other ways. And, in terms of health equity, so during the pandemic, we learned, telehealth for so-called audio only, for people who only have access to a phone rather than a computer or a smartphone, it makes a big difference for people who are lower income, more remote, don't have access to broadband. We still have a large swath of our state that doesn't have broadband. So that's one example. And, the social determinants is really important. Our hospitals are committed to working on it. And at the same time, we really need partnership from everybody else. There's huge investments needed, huge collaboration. I'm encouraged by what people have started to do, including the state. The people on sharing the screen with me today have all demonstrated concern for addressing social determinants of health. It is truly a team effort that's going to be needed to move the needle. One of our goals under the SLIHIS, the Statewide Integrated Health Improvement Strategy, is to lower incidences of diabetes, and it's going to be measured by, body mass index as an indicator. And we can joke about the famous COVID-19 as in the 19 pounds we all gained during COVID, but it's not a joke. And we already had an obesity problem, and it's just getting worse. And we all need to move together on changing that, as well as so many other measures. And in terms of the model impacting the health of people other than Medicare, our opioid measures, that's largely not a Medicare issue. The maternal and child health measures are obviously more focused on moms and kids. And so I think we're starting to steer the model in the right direction in terms of disparities and the breadth of the population.
Josh, you trying to jump in?
Yeah, maybe just to say I appreciate that. And, I certainly have learned to see this as something that is evolving in the right direction and amenable to a lot of engagement around the right direction. When I was secretary, I had less patience than I have maybe now, but I remember right at the beginning, one of the things that was of a lot of interest to the health department was setting up joint funds that could be invested in hospital community partnerships around specific issues. And we started that a little bit. I think at the time, everyone was very anxious about the new model starting, and, really having that be a robust part right out of the gate was difficult. But that has grown over time, and it's gotten to the point where there's some more and more ambitious. I've been not directly involved for 5 years now, just watching it. And I wondered, I was so interested in seeing those kind of collaborations. Would they just shrivel up after I left? And in fact, they've gotten bigger over time. One of the biggest ones now in the Baltimore area, a number of hospitals and community organizations are working together on improving crisis services for mental health and addiction. And that is going to have a pretty large community component as it's being drawn up. It could well include, a whole approach to behavioral health emergencies that really dramatically reduces reliance on law enforcement, for example, and gets people into care that they need at the right level much quicker than before. It's a really exciting initiative as it's, developing. It's a major public-private collaboration as well. And I think that, to me, the fundamental incentive to do that kind of thing has always been there. There have been a lot of tasks to get this model, really functioning that have happened. But the longer we can stay the course, the more, capacity there'll be to put. And in that case, I think it's a $40 or $50 million initiative. It's really a fundamental change that, frankly, other parts of the country don't have the ability to access funds like that because of the way that we're structured here. There are these opportunities, and there is this process to try to sort out what the best ones are and have programs that cross between clinical care and other social functions that in the end really produce a huge amount of value for Maryland.
Right, and important is understanding and having a process in place, Josh, for all these amazing initiatives that are underway. We need to be sure that we have a mechanism to measure them, to measure the outcomes, to measure the savings, because it is critical that we capture those dollars, those investments, that not in the hospital systems alone, but every component along that trajectory. And I think you're referring to the mobile crisis work that is underway. There will be savings if done right across the continuum. More dollars to invest in those other initiatives that are promising for that will address social determinants and other healthcare disparity issues in the state. I think we're at time. Joe or Bob, Josh, any closing comments, points that you'd like to make?
Joe?
I just want to thank everybody, and we've noted the questions and the kind comments in the chat, and onward together. And we're very fortunate that we have the hospitals that we do have in Maryland, and we're fortunate that we have the skilled nursing and rehab centers and the physicians, all of us getting people home faster and healthier. And so I can't thank you, Maria, Josh, and Bob enough for this and for all you do.
Well, yeah, and I see a question last question. How can the waiver model encourage more access to primary care providers through increasing supply? That's a good question. We need more than just the model itself to provide the resources to expand the supply of primary care. So given the time constraint here, I think we'll have to say that's a take-home question, and we will follow up with you, Mr. Powell.
On the physician, if we had Howard Haft here from the Department of Health on the primary care physician front, he would say that the contract gave us an advantage in fighting COVID-19 because via the contract, we have engaged literally thousands of physicians in Maryland on issues of primary care, but we need more of them.
Yeah. But I think Bob's point is a good one, which is the this is not all of healthcare in Maryland, but it is a really important part, and it creates alignment for these other really important goals, including expanding the number of primary care doctors, which is a very important health goal. And even where there aren't direct connections, there are often indirect connections and projects that can be developed. So I do think my final thought, Maria, is just that, also a little unique to Maryland is a lot of what is purely a private effort in other states. It's just chaos of private actors, insurers, healthcare providers. In Maryland has this public component, and that creates opportunities for people to engage in different parts and help make the overall system successful.
Well, I want to thank Joe and Josh and Bob for this very informative conversation. I suspect that one of the things that I most appreciate about our healthcare and landscape in Maryland is that we know when we have to lock arms and work together. I anticipate that will be the case over the course of the next few years as we explore ways to enhance and improve our waiver contract with CMS. I have no doubt that we will get to a place that continues to bring value to not only the Medicare population, but our broader population in general. And I look forward to those conversations. So thanks everyone for your questions. Thanks for the thoughtful dialogue, and looking forward to the rest of the day.